Hello, my name is Tomas Garzon Mufti, and I will be discussing our chapter, Brain Tumors During Pregnancy by Tomas Garzon Mufti, Thomas Kostowski, Rory Goodwin, Mohammed Biden, and Alessandro Olivi. The objectives of the chapter are to understand the management of the pregnant patient with a brain tumor. Also, we seek to understand the effect of pregnancy and brain tumors and their behavior. We want to develop an algorithm to make diagnostic and therapeutic decisions for the pregnant patient with a brain tumor, and finally, to understand the imaging and operative constraints when caring for pregnant patients diagnosed with a brain tumor. The diagnosis of a brain tumor is a challenging event in anyone's life. This is further compounded by the complexity when the diagnosis is made in a pregnant patient. The decision-making process is complicated by considerations of the health of the pregnant patient as well as the unborn child. Additionally, we have to consider the nature of the tumor and need for surgery with or without adjuvant therapy. The incidence and diagnosis of brain tumors is the same in the pregnant patient as compared to a general population. Also important to consider is that there are well-documented effects of the hormonal and physiological changes during pregnancy on tumor biology. It's extremely important to obtain imaging studies for the diagnosis and to generate treatment plans for the pregnant patient. One of the priorities, though, is to minimize the administration of contrast and also the exposure to ionizing radiation for obvious reasons. MRI is an excellent imaging modality for any brain tumor, and this minimizes the use of ionizing radiation for pregnant patients. There is a theoretical risk of creating problems with some migration of cells and developing organs during development, and there's also risk of injury due to the noise that the MRI generates. However, there's no clear association based on the current evidence, and thus MRI is considered to be safe in any trimester during pregnancy. The American College of Radiology guidelines document on MR safety practices states that MRI should be performed only when it is absolutely necessary, and that MRIs for follow-up of existing intracranial masses should not be performed in the first trimester unless clinically indicated. CT scans of the head are relatively harmless given the distance between the head and the fetus. However, it is important to minimize ionizing radiation as much as possible and should be avoided unless completely necessary. In regards to the administration of contrast during pregnancy, it is known that iodinated contrast may have an effect on the uptake of iodine in the fetal thyroid gland, leading to hypothyroidism. Gadolinium-based contrast have shown teratogenic effects in animal studies. Although there's no evidence in humans, it is advisable to avoid administration of gadolinium-based contrast if at all possible. Once we have finalized the diagnostic studies, it is important to decide whether or not the patient would benefit from a surgical intervention for tumor resection. The decision to proceed with surgical intervention is a joint decision between the patient, the neurosurgeon, the obstetrician, and the anesthesiologist. The decision to recommend surgery will depend on the nature and location of the lesion, as well as the associated neurological symptoms and risk of progression. Also, we have to consider the risk to the fetus by undergoing general anesthesia and the stress of surgery in terms of teratogenicity, causing preterm labor, and risk of stillbirth. One of the most important parts in planning operative intervention for patients with brain tumor includes general anesthesia implications towards pregnancy. We believe that by addressing this problem in a multidisciplinary fashion, including neuroanesthesia and obstetrics, this will then well documented that neuroanesthesia for the treatment of second trimester of pregnancy does not appear to have a major increase in birth defects or preterm labor. However, it does increase the risk of spontaneous abortion. That being said, there are very recent animal studies that suggest that fetal brain is sensitive to anesthesia during the first and second trimesters, and the main problem that it causes is deficits in neuronal migration. Similar considerations during the preparation for a craniotomy in the pregnant patient includes the positioning to optimize venous return. The anesthesiologist has to consider changes in ventilation and respiration during pregnancy, and it is necessary to monitor the fetal cardiac activity with a cardiotocograph. It is also very important to limit hyperventilation and vasoconstrictors to maintain blood pressure towards the placenta. These maneuvers can cause placental vessel constriction and decrease perfusion. All these tragedies that I have discussed are aimed to prevent hypotension and hypoperfusion to the placenta and the fetus. In terms of discussing the scenarios of childbirth in patients with brain tumors, there are three hypothetical scenarios. One includes simultaneous craniotomy and delivery of the child. The second includes delivery followed by craniotomy. And the third one consists of craniotomy and subsequent delivery. All these scenarios include important considerations. For example, delivery followed by craniotomy will have to consider the precautions needed for patients with elevated ICP, including the potential risk of a wet tap during epidural anesthesia, among others. In terms of the delivery options, obviously we have the option of vaginal delivery versus C-section. And in general, we prefer cesarean section in patients with brain tumors to prevent spikes in intracranial pressure. That being said, there is a lack of data to formulate recommendations. Additionally, these recommendations will depend on the size of the tumor, the nature of the tumor, and the associated mass effect on the underlying brain. Now, going specifically to different types of intracranial tumors, we will start by discussing pituitary tumors that are one of the most frequent intracranial tumors. Nowadays, with medical treatment to normalize hormones, it is possible to achieve a pregnancy in patients with pituitary tumors. It's important to notice that pituitary gland can increase in size significantly during pregnancy, as shown in the figure. Additionally, pituitary adenomas can have symptomatic enlargement and growth during pregnancy in approximately 15% of the patients. However, the incidence of pituitary tumors does not differ from that in the general population. The treatment strategy will depend on the symptoms and manifestations, which can be due to hormonal secretion or mass effect. In general, the management of most pituitary tumors during pregnancy is conservative unless there is significant tumor growth or hormone secretion. In regards to conservative management, it is done via serial observations with imaging studies, as well as visual evaluations. This is for non-secreting tumors. Surgical treatment is reserved for patients with progression of disease, apoplexy, or hormonal secretion. In terms of treating hormone-secreting tumors during pregnancy, it is known that bromocriptine and cabergoline are safe in pregnancy. This has been demonstrated in long-term follow-up series where there is no evidence in harm to the fetal development. In terms of acromegaly, treatment for acromegaly with somatostatin analogs has to be discontinued within the first month of gestation. In patients with Cushing's disease, we believe that surgical treatment may be safer than medical management due to the implications to fetal health. That being said, we want to repeat that most pituitary tumors can be safely managed conservatively during pregnancy. Let's switch gears to glial tumors. These constitute approximately 35% of all intracranial tumors. And although the incidence of glial tumors does not change during pregnancy, we frequently see young pregnant women with low-grade gliomas due to increased symptoms. This increase in symptoms may be due to some changes that the tumor undergoes secondary to increased angiogenic factors, increased blood volume, and increased cerebral edema. It's also necessary to get a diagnosis, and this is primarily done with neuroimaging studies. And as we mentioned before, this should be done with an MRI. Now, in treating medically some of these patients that have gliomas and present with seizures, we have to consider the treatment with anti-seizure medication. We know that a lot of these medications increase teratogenicity, and this is seen more frequently with polytherapy. Some of these agents, such as phenytoin, have heart and orofacial malformations risk. Carbamazepine and valproic acid have a risk to cause neural tube defects, and more of the newer agents such as lamotrigine or levetiracetam have safer profile and are reserved for patients with uncontrolled seizures. Patients undergoing treatment with anti-seizure medications should be supplemented with higher doses of folic acid. In this slide, we present the case of a 34-year-old woman that presented with right homonymous hemianopsia. She had had some nonspecific symptoms towards the latter end of her pregnancy, but she had attributed these to pregnancy symptoms. Post-delivery, she complained about having visual problems, and she underwent an MRI that shows this large left-sided tumor. After delivering her child, she underwent surgical and adjuvant treatment. As we all know, the treatment modalities for glial tumors include surgical resection, stereotactic biopsy, management of obstructed hydrocephalus, and adjuvant therapies such as ionizing radiation and chemotherapy. These can be postponed until after delivery, and in some situations, stereotactic radiosurgery has been used as an option with minimal scatter of the radiation. The third and last broad category of tumors that we will be reviewing in this chapter includes meningiomas. These tumors also do not change in prevalence or incidence in pregnant patients as compared to a general population. They constitute about 18% of all intracranial tumors, and these tumors can increase in size during pregnancy and regress after delivery. This is thought to be secondary to the hormonal changes and total blood volume changes in pregnant patients. Diagnosis is made through neuroimaging studies, and as we said before, MRI is the preferred category. Most cases, treatment can be postponed until after. In this slide, we present the images of a woman that presented in the second trimester with a very large mass-occupying lesion in the left parasagittal region. The management that we performed for this patient was to manage her conservatively until she delivered her child, and then she underwent surgical resection of this left parasagittal meningioma. Here we present the schematic that we use to treat a pregnant patient with a brain tumor. Initially, when the patient presents with neurological symptoms, an image is obtained to diagnose the lesion. Then we can broadly divide the lesion into the three categories discussed in this chapter, including glioma, meningioma, and pituitary tumor. Then we have to decide what the types of management we're going to administer. In the medical management category, we can manage some mass effect with corticosteroids. We can manage seizures with anti-seizure medication, and pituitary tumors that are secreting can be managed with some hormonal therapy. However, when we decide that the patient should receive surgical management, we have to consider three very important facts. One of them is the stage of the pregnancy, neurological symptoms, and maternal health. In the middle, you see this triangle that is made to symbolize that the management and treatment decisions should balance all three of these categories, including maternal health, fetal health, and optimal outcome. Other tumors that can change in terms of behavior during pregnancy include hemangioblastomas that can increase in size during pregnancy due to the angiogenic factors. Lymphoma can progress due to immunodeficiency in pregnancy, and although rare, metastatic tumors can be encountered in pregnancy, and definitive treatment should be provided. In conclusion, the incidence of brain tumors in pregnant women is no different to that of the general population. There are well-documented studies showing how the behavior of some of these intracranial tumors can change in pregnancy due to hormonal changes, blood volume changes, and angiogenic factors. The management of the pregnant patient with a brain tumor should be carefully designed to prioritize the health of the patient and the fetus. We have found that multidisciplinary approach, including neuroanesthesia, obstetrics, and neurosurgery, is paramount to the optimal outcome of these patients. Thank you.